speaker who is also one of our speakers yesterday during our day 1 of the webinar. She is a clinical pharmacist of the AICU of Baycare Health System in St. Petersburg, Florida, USA. She is a certified ICU Liberation instructor by the Society of Critical Care Medicine or the SCCM. And she is also a board-certified critical care pharmacist by the Board of Pharmacy Specialists. She had her residency training in critical care pharmacy at the Lakeland Regional Medical Center in Florida. She also took her residency training in pharmacy at the Spartanburg Medical Center in South Carolina. She earned her doctorate of pharmacy at Presbyterian College, the School of Pharmacy in Clinton, South Carolina. And today, to discuss the acute respiratory distress syndrome, again, let us all welcome Dr. Rebecca E. Conley.
Acute respiratory distress syndrome. Although it used to be a haunting term for any intensive care unit team member, this is now a term we have all likely become way too familiar with during the times of COVID. ARDS, as it is referred to for short, used to be one of those disease states you saw infrequently and usually denoted your sickest of sick patients. Those patients were likely to crump and fall to pieces at any moment. Not so much anymore, as this pathological process has risen to the forefront of daily rounds in most ICUs across the world. We can all dream of a time when ARDS cases go back to few and far between. In the meantime, during the COVID-19 pandemic, it's a great time to refresh ourselves on this syndrome. My name is Rebecca Conley, a critical care pharmacist practicing in Florida, and I hope you enjoyed this presentation, as it is one of my favorites. I will disclose that compensation has been provided for the development of content and the presentation. No funds were provided to endorse any medication or product from the compensating entity. This is a topic that I am excited to share with you all today, and I did choose myself. As we go through this lecture today, our objectives will be to explain the pathophysiology of acute respiratory distress syndrome, present ARDS diagnostic criteria you will see in patients, determine a stepwise approach to ARDS management using evidence-based medicine, and we will discuss literature surrounding the use of medication therapy in ARDS. Worldwide, it is approximated that there are anywhere between 64.2 and 78.9 ARDS cases per 100,000 person years, with the mortality range being highly variable from anywhere to 40 to 60% reported in literature for severe ARDS. Analysis of prevalence and incidence worldwide is somewhat difficult due to inappropriate use of ICD-10 and 9 coding, as patients may be misdiagnosed either positively or negatively, allowing for inaccurate capture. A study by your work and colleagues published in 2018 analyzed the incidence of ARDS in the United States over the course of 6 years. At the time of publication, this was thought to be the most accurate representation of patients with ARDS, but again, due to our current state of pandemic, these numbers would likely be much different if the study were repeated at this time. The findings showed that over 1 million ARDS patients were discharged, and 80% of those shared commonalities with the updated definition of ARDS established by the 2012 Berlin definition, which was released halfway through the data collection period of the study. As far as the patients at the greatest risk of ARDS, the findings showed a median age of 65 years old, with 76% being of white descent and 54.4% being males. The average length of stay of these patients were 15.4 days and reached up to over 30 days in some patients. Greater than 96 hours of mechanical ventilation was required for just under half of the assessed population, with 33.9% dying while inpatient and 32% of those surviving to discharge being discharged to some sort of care facility. This denotes the devastation of a syndrome like ARDS can have on not only mortality across subjects, but also their morbidity. Since ARDS was not considered to be a primary diagnosis, but a secondary syndrome developed due to a leading cause, primary diagnoses were recorded for all patients. The top 3 concomitant diagnoses were sepsis, pneumonia, and shock, all coming in at right under 50% of the population. It is thought that these insults to health not only cause the initial insult trigger of the inflammatory cascade, but that also adds to the quick progression of ARDS. Of note, when mortality was assessed, the leading cause of death originated with shock and sepsis-related ARDS. On a positive note, over the course of the years of the study, they did see a decrease in mortality from shock, from 50.6% to 44.9%, and also in sepsis, from 46.4% to only 40.7%, again during those 6 years of study period. Other risk factors associated with ARDS that have been proposed in other literature include advanced age, female gender, past history of smoking, alcohol use, following cardiovascular surgery or in traumatic brain injury patients.
Let's talk anatomy and physiology for a minute, starting with healthy subjects. Alveoli within the lungs are responsible for gas exchange. Blood that is oxygen depleted and carbon dioxide rich is brought to the lungs via the pulmonary artery. The dense capillaries surrounding each alveolus actually facilitates the passive exchange of gases. Inhale, exhale, gases are exchanged. ARDS is a type of respiratory failure that occurs due to the loss of functional alveoli and therefore the loss of gas exchange, leading to hypoxemia and hypercarbia. In the picture, we can see normal alveolus in comparison to an injured alveolus during the acute phase of lung injury that occurs during ARDS. Capillary leak is a common systemic issue that occurs during inflammatory states caused by both indirect injury, such as with sepsis, multiple blood transfusions, and burns, as well as from direct injury, such as with pneumonia, pneumonitis, or embolism. The exudative phase of ARDS occurs within 1 to 3 days following injury. During this phase, capillary leak allows protein-rich fluid to cross into alveolar sacs, creating pulmonary edema that will progress into alveolar collapse and atelectasis, therefore depleting the ability of all gas exchange in those alveolus, resulting in, again, hypoxemia. As injury progresses, membranes become rich in hyaline, and the lungs will lose the ability to expand and contract freely. This is actually when we see ventilation to perfusion mismatch really become apparent. The lungs can no longer exchange oxygen, also known as ventilate, at the rate the body needs to oxygenate its tissues, also known as perfusion. The next phase is proliferation. During this time, attempts are made to repair the damaged tissue. Unfortunately, the tissue generation during this phase is very fibrous, taking away from the elasticity factor the lungs actually need to expand and contract. As more blood is brought to the area for tissue regeneration, more fluid may also move into the interstitial spaces around the lungs. This creates even more resistance against the ventilation aspect. Sometimes this may be referred to as a stiff lung. I'm sure you've heard that before. Towards the end of the proliferation stage, reuptake of the leaked fluid will slowly take place, providing resolution to the pulmonary edema, but this is a slow process. The late fibrotic stage may start as early as 10 days into the disease. Although not all patients develop permanent damage from ARDS, there is a possibility for patients to develop collagen deposits, fibrosis, and long-term respiratory complications. There's a link at the bottom of this slide I have included that is a YouTube video of a nurse educator who does a really good job of explaining the pathophysiology if you want more detailed information.
Just like with the pathophysiology of ARDS, there are also phases of patient presentation, although the two are not necessarily related. The chart of symptoms on this slide occur in both the exudative and proliferative phases of ARDS. I won't spend time talking about each of these, but there are a few key features I would like to point out. First, let's assess heart rate and cardiac output. As indicated by the arrows, in early to mid phases of ARDS progression, the patient will experience increased heart rate and therefore an increased cardiac index. This is the body's attempt to deliver as much oxygen through the blood to the tissues as possible. The heart is trying to compensate for the oxygen deprivation in blood as a result of loss of gas exchange. This is correlated directly with the increase in PaCO2 concentration over time. However, this is not sustainable, and eventually both heart rate and cardiac index will decrease, leaving you with a crashing patient who is also likely to be in a mixed acidotic state in comparison to the respiratory alkalosis normally seen in the early moments of ARDS. As we talked about previously, the shunt fraction also increases over time, and lung compliance continues to worsen as the syndrome progresses. As lung volumes become more and more compromised, imaging will begin to reveal atelectasis and consolidation. From the standpoint of patient assessment, changes in lung sounds from clear to the development of crackles, wheezes, and rhonchi will be evident with worsening illness. Signs and symptoms of early ARDS may be dyspnea and fatigue, but can quickly escalate to cyanosis, arrhythmias, hypotension, or even respiratory arrest.
ARDS is a syndrome and not a disease state. It takes more than just a lab result or a test to diagnose the problem at hand. Prior to 2012, there were a mixed definition of ARDS out there. However, in 2012, the Berlin definition was established and laid out specific diagnostic criteria for the syndrome to be used worldwide. First, the Berlin definition says that the onset should be within 7 days of known insult or respiratory symptom onset. That chest imaging should show spontaneous bilateral opacities not due to effusion, lung collapse, or nodules. Pulmonary edema is present but is not directly related to cardiac failure or volume overload, and that compromised oxygenation will also be present as defined by the PF ratio, or the ratio of serum oxygen compared to the amount of oxygen inspired, and a PEEP requirement of 5 or more. Looking at the chart, mild ARDS may be present in patients on non-invasive ventilation strategies such as CPAP or BiPAP, and the PF ratio will be greater than 200 but less than 300. The mortality of even mild ARDS is around 27%. Moderate ARDS is classified as a PF ratio less than 200 but greater than 100, and normally by this point patients are intubated. Severe ARDS is defined as a PF ratio less than or equal to 100 and carries a mortality rate of up to 48%. In clinical practice, many use a PF ratio cutoff point of 150, falling right between moderate and severe ARDS as the point of worry or trigger for initiating interventions.
Some of the most beneficial interventions we can have for patients suffering with ARDS are through supportive care and management of the ventilator. Our goal should be to support the patient's oxygenation while minimizing further insult to organ damage. Conservative fluid management has been shown to be a beneficial impact on patients, and also when looking at ventilator management, using low tidal volumes of 4 to 8 mL per kilogram of ideal body weight and maintaining plateau pressures less than 30 have been shown to improve outcomes. Pronation is also an intervention you should always consider when thinking about a patient in severe ARDS. It has been shown that pronation has beneficial effects when used for over 12 hours per day. If you look to the image on the screen, you can see that when the patient is in supine position, a lot of the lung volume is not able to be used. Whereas when the patient is turned to the prone positioning, the light purple area expands and the patient has more usable lung space. Ventilation settings in ARDS has become increasingly important over the years. In 2000, the ARDSNet criteria was produced through a publication. The clinical question at hand was, does the use of lung protective ventilation compared to traditional ventilation actually decrease mortality and or increase ventilator-free days in patients suffering from ARDS? The comparison was against traditional ventilation, including tidal volumes of 10 to 15 mL per kg and plateau pressures of 45 to 50. In the lung protective strategy, tidal volumes were reduced to around 6 mL per kg and plateau pressures were maintained between 25 and 30, creating less barotrauma on the lungs, hinting towards the protection theory. This was done in 861 adult patients, with the intervention being proposed and used on 432 of those. The outcomes showed benefit. At 180 days, there was a decreased mortality. Thinking back to the pathophysiology of ARDS, it makes sense that fluid management would need to be a consideration when caring for these patients, as both capillary leak and pulmonary fluid collection play a huge role in the development and progression of acute respiratory distress syndrome. The FACTT trial of 2006 asked the clinical question, what benefit would the use of a conservative versus liberal approach to fluid management have when using positive pressure ventilation per the ARDSNet protocol? The study enrolled 1,000 adult patients with ARDS, designating 533 to a conservative fluid approach. In the liberal fluid group, central venous pressure, also known as CVP, targets were considered to be physiologically normal at greater than or equal to 5 milligrams of mercury. Whereas in the conservative group, CVP targets were actually less than 4, hence the idea that providers may choose to run an ARDS patient dry, and that means that they are limiting as much fluid as possible. Follow-up was completed at both 28 and 60 days, with a significant finding for the primary outcome of decreased all-cause mortality at 60 days being found. Other key findings of the study showed no difference in the need for dialysis initiation at 60 days, increased ventilator-free days, and an increased number of ICU-free days within the first month following enrollment. The FACTT trial is considered to be a landmark trial when looking at changing the course for ARDS patients. Another key landmark study that changed the course of care for ARDS patients was PROSEVA. This study was published in 2013 and looked at the utility of prone positioning in comparison to supine-only positioning at 28 days follow-up time. Prone positioning aims to improve ventilation perfusion match through aeration of lung spaces that were previously compromised by atelectatic alveoli. During this study, 466 patients with severe ARDS in European ICUs were assigned to either prone positioning within 36 hours after intubation and maintained for at least 16 hours, versus a standard supine position group. Upon evaluation at the study endpoint, the prone position population had a 51% relative and 17% absolute reduction in all-cause mortality when compared to the supine group, with a number needed to treat of only 6 patients. Since prone positioning was an additional care standard being added to the standards of care already established, such as lung protective ventilation and the use of paralytic therapy, it is assumed that prone positioning adds benefit beyond the usual patient care. Other findings of the study included decreased mortality at 90 days, no difference in time to successful extubation, and an increase in ventilator-free days at 28 days of follow-up. Their pronation protocol of early assignment to pronation and maintaining the position for at least 16 hours per day is used as the basis for protocols all across the world. Prior to the study titled Efficacy and Safety of Corticosteroids for Persistent Acute Respiratory Distress Syndrome, published by the Acute Respiratory Distress Syndrome ARDS Clinical Trials Network, the overall consensus on the use and benefit of steroids in ARDS was yet to be determined, as several studies have been published already with some in support and some showing either no benefit or even harm associated with the use of steroids. Before use of steroid therapy for any indication, it is always responsible to review the risk associated with the steroid therapy, including the risk of infections, hyperglycemia, poor wound healing, psychosis, pancreatitis, and even prolonged muscle weakness. Given the relationship between the onset and progression of ARDS with inflammatory markers, the use of steroids in theory makes great sense to downregulate that pathological process. The question addressed by the study was, would the use of at least 7 days of methylprednisolone therapy when compared to placebo reduce mortality at 60 days? Methylprednisolone was dosed as a one-time bolus of 2 mg/kg, followed by a weight-based taper schedule for at least 21 days. 180 patients were enrolled within 7 to 28 days of ARDS diagnosis over a 6-year study period. Of these patients, 89 were randomized to receive the steroid regimen. For the primary endpoint of mortality at 60 days, there was no significant difference found between the intervention and control populations. Steroid therapy did prove beneficial in reducing both ventilator-free and shock-free days at 28 days. Other secondary endpoints worth discussion are that there was no impact on mortality at 180 days, and there was actually an increased risk of mortality associated with death at both 60 and 180 days when methylprednisolone was started 14 days after the onset of ARDS. After this study publication, the recommendation surrounding steroid use in ARDS was that the evidence does not support routine administration of methylprednisolone therapy for persistent ARDS, and that starting steroid therapy more than 14 days after the onset of ARDS actually increases the risk of death. In contrast to the previous study discussed, and in light of the times of COVID-19, where we are using mass steroids in patients with an ARDS-like diagnosis due to viral pathology, I would like to present a newer article published in 2020 that focuses on the analysis of the use of dexamethasone in ARDS. The study set out to address the following question: will the use of dexamethasone for pulmonary and systemic inflammation during ARDS result in decreased duration of mechanical ventilation and mortality? For this study, dexamethasone was dosed as 20 mg IV daily for 5 days, followed by 10 mg daily for an additional 5 days. One of the key reasons dexamethasone has been chosen in COVID is due to a less likely risk of water retention resulting in fluid overload and potentially pulmonary edema, which is also ideal to avoid an acute respiratory distress syndrome that many of our COVID patients go on to develop. The multi-centered randomized trial occurred across 17 ICUs in Spain and enrolled 277 patients with moderate to severe ARDS, assigning 139 to the intervention group and 138 to the control. The study was stopped early due to low enrollment after reaching only 88% of the desired population. For the primary outcome of the total number of ventilator-free days at 28 days, a significant difference was detected, favoring the use of dexamethasone and lowering days on the ventilator by an average of 4.8 days. The secondary outcome of all-cause mortality at 60 days after randomization also significantly favored dexamethasone use. The rate of adverse events did not differ significantly between the intervention and control group. The most common adverse events were hyperglycemia, seen in 76% of patients receiving the steroid and 70% of those in the control group. The study brings to light that individual agents may have properties that hinder or facilitate their use in certain disease states, and that class effect cannot always be assumed. Although a small study, the evidence supports early administration of dexamethasone that could reduce mechanical ventilation days and mortality in patients with moderate to severe ARDS.
As a general overview, the treatment of ARDS can be thought of as a stepwise approach. First, using ventilator settings to aid in the recruitment, ventilation, and oxygenation per the ARDSNet protocol and getting the patient into a position of being proned. The next step would be to increase sedation if necessary and consider the use of a neuromuscular blockade to aid in ventilator synchrony. In very refractory patients, inhaled epoprostenol or even ECMO may be used as last-line options. Ventilator compliance can often be a problem in these patients. Mechanical ventilation in general is very foreign and unnatural to the body, but ARDS ventilation steps that up. Many of these patients may require deep sedation in order to tolerate the ARDS ventilation settings, but deep sedation should be tried first to consider the need for true paralytic therapy. Neuromuscular blockade therapy has been studied in ARDS patients twice in the past, once in 2010 in the ACURASYS study, which did show there was a reduction in mortality when a neuromuscular blockade was used early on in patients with a PF ratio less than 150. The interesting thing about this study is that the neuromuscular blockade was not titrated to effect. It was started at a flat rate and continued at that rate for 48 hours. Once at 48 hours, the neuromuscular blockade was stopped and it was looked at to see if it had provided enough benefit to then be discontinued or if continuation was needed. The study proved that 48 hours of use of this flat rate was beneficial. Almost 10 years later, the ROSE trial, which came out just in 2019, was published and found there was actually no difference in mortality for patients who underwent the usual care considered to be light sedation strategies in a neuromuscular blockade as a PRN only as necessary in cases of very severe ventilator dyssynchrony. They found, again, no benefit with neuromuscular blockade therapy versus light sedation, basically contradicting everything that the ACURASYS trial had told us. Regardless, if a patient is going to undergo neuromuscular blockade therapy, it's very important for us as pharmacists, you guys as nurses, and even physicians to really pay attention to the level of sedation. The goals of sedation therapy, be it either a pain medication such as fentanyl or Dilaudid, or propofol and Versed as sedatives, the goal should be changed to RASS -4, -5, and a BIS monitor should be maintained on the patient throughout neuromuscular blockade therapy. The goals for BIS monitoring may be around 30 to 50, with an ideal range of around 40 to 45. It's also important to understand that the prolonged use of neuromuscular blockade therapy increases the risk of ICU-acquired weakness, which can be long-lasting and very devastating. To the side, I have developed a stepwise approach to what we just talked about. Again, first, if you have ventilator dyssynchrony, making sure the patient has adequate analgesia and sedation to a RASS -4, -5. At this time, you would need to reassess ventilator compliance. Often these patients undergoing deep sedation no longer need to be paralyzed. If you find the patient is still fighting the vent and is not compliant, then a neuromuscular blockade therapy may be required. The next step should be to place the BIS monitor and maintain your BIS range of 30 to 50. Once the BIS range is reached that is desired, you may start the neuromuscular blockade therapy. At this point, RASS assessments and pain assessments are both invalid, so all you have to go off of for sedation is to assess the BIS number.
The first landmark trial addressing the use of paralytic therapy in acute respiratory distress syndrome is also known as ACURASYS, or the Pathophysiology trial, and was published in 2010. The study addressed the following clinical question: will the use of cisatracurium, a neuromuscular blockade agent, improve survival in comparison to placebo in early severe ARDS requiring mechanical ventilation? Paralysis with cisatracurium was achieved by using a loading dose of 15 milligrams, followed by a flat rate continuous infusion of 37.5 milligrams per hour for 48 hours. Peripheral nerve stimulators nor the titration of the paralytic were allowed in the intervention group during this time. The study randomized 340 patients across 20 ICUs in France to either receive paralytic therapy or placebo within 48 hours of the diagnosis of ARDS. Therapy with cisatracurium was associated with a 9% absolute reduction in mortality at discharge or at 90 days, working out to a number needed to treat of only 11 patients. Use of paralysis also significantly decreased barotrauma events, including pneumothorax, days of required ventilation, and ICU admission days. Contradictory to the significance of the primary endpoint, mortality at 28 days was not different between the two groups. Criticisms of this study include, but are not limited to, the use of only one neuromuscular blockade agent at a dose that was not confirmed to reach effective paralysis, as well as concerns that later initiation of a paralytic therapy may not show the same benefit, and that the study was underpowered as demonstrated by the lower than expected rate of mortality seen overall. Almost 10 years later, a follow-up study by the National Heart, Lung, and Blood Institute, also known as the PEDAL Clinical Trials Network, was published and challenged the information found in the Papazian study of 2010. The Rose study, released in 2019, readdressed a similar question. Does the use of continuous infusion neuromuscular blockade therapy using cis-atracurium improve mortality compared to the usual care of patients with light sedation? The study question brings attention to the use of light sedation, which is very timely as more and more evidence has been released and is continuing to be released about the detrimental side effects related to the use of long-term paralytics and deep sedation in the ICU population. In the control group, deep sedation was used in combination with the same 48-hour, non-titratable dosed continuous infusion of cis-atracurium. In the intervention group, patients were kept at a Richmond agitation sedation scale of 0 to -1 and were allowed only as-needed neuromuscular blockade boluses for control of intermittent asynchrony. Across 48 hospitals in the United States, 1,006 patients were enrolled and followed for up to 12 months. There was no difference in the primary outcome of in-hospital death due to any cause at 90 days, signifying use of light sedation and as-needed paralytic administration was just as effective as the previously suggested continuous infusion paralytic proposed. Other outcomes of interest without difference between the two groups were the rate of in-hospital death at 28 days and the number of ventilator-free days at 28 days, again supporting an as-needed approach only to the use of paralytics. In refractory patients who are experiencing severe or worsening oxygenation status due to ARDS despite the standards of care, there may be a role for inhaled epoprostenol therapy. As mentioned previously, at this time there is no literature showing any kind of direct benefit and outcomes when epoprostenol therapy is added. However, some of this may be due to extremely high rates of mortality in these patients, being as high as 48% in severe ARDS. Epoprostenol therapy may be attempted prior to starting extracorporeal membrane oxygenation, also known as ECMO, as a bridge to ECMO, or when patients are too critical to be transported to an ECMO center. Most patients who have progressed to this level of ARDS requiring epoprostenol therapy are too severe and are not going to be stable enough for transport. Based on the mechanism of action, we do know that the drug will improve oxygenation status. Unfortunately, at this time, that has not been able to be tied to a mortality benefit. Epoprostenol works as a pulmonary vasodilator. It is used primarily in pulmonary hypertension as an IV agent. By using the inhaled version of this medication, the rate of side effects are decreased and there is an increased effect in localized activity. Epoprostenol helps recruit blood flow to functioning alveoli remaining in the lung to increase gas exchange and therefore oxygenation. It also decreases shunt fraction and hypoxia. Since the drug is used for refractory patients only, many centers develop specific criteria for use. Examples of criteria may be as follows. Anytime the patient is in ARDS with a PF ratio less than 60, or when patients are in severe ARDS defined as a PF ratio less than or equal to 150 who continue to have hypoxia. Due to evidence-based approaches, patients who should be considered refractory should have already been tried on adequate times of both ARDSNet protocol ventilation and pronation therapy when feasible. Another option for refractory therapy is making use of ECMO for patients failing all other treatment modalities. Due to time constraints, ECMO will not be discussed during this presentation. Many studies have been conducted to try and pinpoint exactly what can be done to treat patients that are in ARDS. Throughout this presentation, landmark trials and their contributions to the care of patients with acute respiratory distress syndrome have been discussed in brief. From a quick review of literature, the most beneficial interventions for patients in ARDS are 1. To approach fluids in a conservative manner. As we discussed with the pathophysiology, pulmonary edema is the root of all evil here, and the last thing we want to do is give more fluid, which could worsen the edematous state. Employing a no to low fluid state helps decrease ventilator days. Another method of care for these patients is using tidal volumes that are known not to overstretch the lungs and cause further injury, which decreases mortality and ventilator days. This can be achieved by following the ARDSNet protocol for mechanical ventilation in ARDS patients. Another beneficial therapy is to employ early pronation, which proved to decrease mortality. In the middle section, there are interventions listed which produced mixed results in mortality outcomes. Although multiple studies have been conducted on the use of steroids, neuromuscular blockade therapy, and extracorporeal membrane oxygenation, or ECMO, these results have been conflicting. The last group of therapy options have been studied and have yet failed to reduce any kind of beneficial outcomes. The use of low versus high PEEP strategies showed no difference in terms of mortality or ventilator days. In addition, high-frequency oscillator ventilation nor the use of inhaled vasodilator therapy has shown to decrease mortality at this time. Thank you for joining me for this talk about acute respiratory distress syndrome.